Good.
Okay, that's good? Okay. Ooh. The hardest part's over. Okay, hi. For those of you I haven't met, my name is Ainsley Bloomer. I am one of the orthopedic PGY2s. Today I will be presenting on Dermabond. Well, let's stick around. We are keeping in our theme of wound care. I have no disclosures relevant to this talk. We will start with a clinical case. This is a 41-year-old male. He presented after ACL with BTB and lateral meniscus repair. He's otherwise healthy, but on post-op day 5, he had concerns for increasing wound drainage on his aqua cell and pain and pruritus. The bandage was removed. He was placed on topical and PO Benadryl, given Keflex for a week, put on Pepcid. This resolved in about a month. I don't have images of that, but he was told he likely has an allergy to Dermabond. So a little history from the development of Dermabond. In 1942, cyanoacrylate was first discovered when they were looking to make clear plastic gun sights in World War II. And then in 1958, an American scientist was credited with the discovery of superglue. In 1959, a British plastic surgeon first used cyanoacrylate as a tissue adhesive. This is Harry Cover. And then in 1985, superglue was actually used for skin graft fixation as there was a large fire and there were limited resources. So this man went out to a drugstore, bought some superglue, and then noticed that the skin grafts actually had really good both cosmetic and wound healing outcomes. In 1998, Dermabond was FDA approved for wound closure. It was less toxic than its predecessors and had 4 times more strength. So what are some of the ingredients included in Dermabond? It is a proprietary product, so we can't know the exact formula, but 2-oxyethyl cyanoacrylate is at a concentration of 94%. This is an acrylic resin that rapidly polymerizes in the presence of water to form these long and strong chains. Cyanoacrylates are very common in household items, and they're actually also used in fingerprint imprinting. They contain violet 2, which is also added to absorbable suture, any purple suture you see, but it is a food coloring, so it does have potential for hypersensitivity. There's plasticizers, stabilizers, polymerization inhibitors, and then some byproducts include formaldehyde and cyanoacetate, which are both known to cause inflammation. Dermabond reaches its maximum bonding strength at about 2.5 minutes, and it's equivalent to healed tissue at post-op day 7. The breaking strength is about 5 times the strength of nylon, and in about 5 to 10 days, as a wound re-epithelializes, the adhesive generally sloughs off. Here's another case example. This is an 8-year-old female. She underwent right knee epiphysiodesis. No past medical history, but she did have a prior ipsilateral epiphysiodesis about 2 years ago. She presented with this reaction to Dermabond. She underwent Dermabond removal, was given Benadryl cream, prednisone, some oral Benadryl, and about a month later, she is doing well. So just to review quickly, hypersensitivity reactions. Type 1 is immediate, it's IgE mediated. Think asthma, and it comes on in seconds. Type 2 comes on in about minutes. This is an antibody-mediated response, but it's local. Example is Goodpasture syndrome. Type 3, this occurs in hours. This is immunocomplex deposition, so it is a systemic reaction, and think more on the terms of lupus. And then for type 4, delayed hypersensitivity reaction, which is what we're talking about today. This is more on the day timeline. We can see this in poison ivy. Symptoms can range from nonspecific pruritus and erythema to a more robust papulovesicular weeping eruption. But once sensitization occurs, any future exposure will typically cause a quicker and more severe reaction. So this was a good article that came out of, there is actually a journal called Dermatitis. This came out in 2022. So they reviewed contact dermatitis in general. The concern was it can mimic surgical site infections, compromise wound healing, result in wound dehiscence, and cause stress and anxiety for the patient. They reviewed suture, tissue adhesives, and staples to identify risk factors. For sutures, this include non-absorbable suture, anything derived from natural products, coated in dyes or exposed to sterilizing agent. For staples, this also includes nickel allergy, although most commonly staples are surgical grade stainless steel, but they can be nickel coated. To review quickly skin healing, the first stage is the inflammatory stage, and this is when you get the influx of the white blood cells. This is about 24 to 48 hours. It coincides with those key signs of inflammation, but the high number of immune cells exist in the subcutaneous space in this time, and this increases the likelihood of a sensitization event if exposed to an exogenous material. And then you have the proliferation phase and the scar remodeling. So as the development of tissue adhesives has occurred over the past 20 some years, they have gotten longer alkyl side chains, which has increased the tensile strength, decreased the rate of degradation, inflammation, and toxic byproducts. The reaction to Dermabond may vary by the environment. If you place it on intact skin, you get quick polymerization on the stratum corneum, which reduces time for skin invasion and thus decreases sensitization risk. But on broken skin, monomers may interact with antigen presenting cells before polymerization is complete. So you get increased risk of this sensitization and possibly hypersensitivity reaction. And then increased exposure time may also occur in dry environments because you need water to undergo polymerization. So it will decrease the polymerization rate. And it's been proposed that increased use of OCA or explain a parallel increase in incidence of related acute contact dermatitis. So what is the incidence? It's been reported anywhere from 0.5 to 7%, but the authors of this paper, based on professional experience, thought it was higher. So they looked at 102 patients who underwent breast procedures and found a 14% reaction rate. To review, there are two types of Dermabond. I think Dermabond Advanced is the most common one known, but there's also Perennial, which is a liquid glue that's then activated by a reagent in a polyester-based pressure-sensitive mesh, combines with moisture in the skin. But you do need both to get a reaction for Perennial. And then, like Dr. Reese talked about, with sharing tension across a wound edge, the mesh helps to do that. You do want to apply it slightly over the edges of the mesh so the mesh doesn't peel, but any excessive liquid you want to wipe off quickly to decrease sensitization, and then you don't need a second coat. This applies to advanced Dermabond as well. A single thin layer coat is enough. Oops. So I have another case for you. It's a 67-year-old male. He underwent right total knee. This is his skin on post-op day 3. It got worse on post-op day 5. They removed the Perennial and left it open to air. He continued to improve after this time, and it's looking great today, but he did delay physical therapy by about 10 to 14 days given this skin reaction. So what are some of the proposed benefits for using a tissue adhesive like Dermabond? The first study is a 40-person randomized controlled trial looking at nail bed repairs. They had half to Dermabond and the other half to 6-O-chromic. At 6 months follow-up, there was no difference in outcome, but the time to closure was significantly different. Dermabond was about 10 minutes and chromic was about 30 minutes. There is a decreased rate of infection with use of Dermabond. This was acetabular fractures treated with the same incision. They randomized to staples versus a running monochrome with Dermabond. In the staples group, they had 2 deep infections and multiple debridements. And then the time to incision was lower in the Dermabond group by about a day. Time to dry incision. Interestingly enough, there's also bactericidal properties to Dermabond. Here's 2 images. The one on the left is gram-negative culture, and the one on the right is gram-positive. So you can see that ring of inhibition, and here are a couple different common skin flora for which Dermabond is inhibitory. And then obviously, improves cosmesis, or cosmesis is a really important factor when closing wounds, and suturing is important to patient comfort as well. This is a This is a study looking at bilateral mammoplasty, and they used the patient as her own control. So one was closed with standard suture closure, and one was closed with Dermabond. And for almost unanimously, the patients preferred the closure with Dermabond. And there was a plastic surgeon panel, and they agreed there was no inferior difference. And then it's also been shown to be more cost effective if you have decreased wound risks and less need for follow-up if you're not removing sutures. So this was a study out of Hong Kong. They closed with Steri-Strips versus Dermabond. Suture versus Dermabond. And they actually mapped out how much it would cost for a patient to follow up for wound check and then suture removal. And it exceeded the cost of Dermabond at the initial closure event. And then additionally, they've done a lot of studies with laparoscopic port sites in the general surgery literature. And it is much more beneficial, especially in the state of kids, to have no sutures that need to be removed at the skin level. This was one of the largest studies I found on this topic. This was a retrospective review of a multi-hospital database looking at spinal fusion surgeries with 2 different sutureless skin closure techniques. They used skin staples plus a waterproof dressing versus Perineo. They found almost 12,000 patients. And then when they did a post-match study comparison group, a little over 7,000. But in the Perineo group, they had statistically significant lower median OR time, mean length of stay, risk of non-home discharge status, and overall infection and complication. And I think the efficacy of using something like Dermabond has improved with time. These are 2 studies to compare. The first one was a blinded prospective RCT comparing Dermabond, subcuticular closure, and skin staples. And all the deep layers were closed the same. They had 187 total patients. Dermabond was associated with less wound discharge in the short term, but was not reported to be overall beneficial. And the closure of the wound with skin staples was significantly faster in the operating room. And there was no significant difference in length of stay, cosmesis, patient satisfaction between the groups at 6 weeks. And these total joint surgeons reported they prefer staples, as opposed to a more recent study in 2020. This was an RCT comparing wound complications and reoperations for Perineo and Aquacel with silver. And they had 347 cases. All their deep layers were closed with quill. They had 2 instances of delayed wound healing in the mesh group and 16 in the standard dressing group. This was statistically significant. And they had significantly fewer operations in the mesh group. So these authors did choose Perineo. This study was a case series study. It was 2020. They looked at Dermabond Perineo with contact dermatitis reactions, but all these patients had confirmed patch testing. They had 6 patients. All 5 reported 5 of these reported previous exposure to Dermabond products. All had the adhesive removed and were treated with corticosteroids. And they had some pretty significant reactions. Only 1 reported infection and had that confirmed with testing. But all of these resolved within 2 weeks, and they had no adverse effects on the orthopedic outcome. They have this is a really good article, including multiple recommendations, but of note, they did recommend completely removing the mesh and adhesive no later than 14 days post-operatively, because there's no benefit after that time, but you can increase the risk of sensitization. So this leads a question for, is there a role for pre-op testing? Who would that include? Can you possibly cause sensitization if the patient hasn't been sensitized with scratch testing? And does Perineo, which has 2 separate components to it, lend itself to more specific testing? These authors looked at patch testing. They looked at multiple different compounds, including different cyanoacrylates. They did say scratch testing, as opposed to patch testing, more closely resembles surgical sites and was more likely to lead a positive result, which I think kind of leads to a secondary question of, if you're going to scratch the skin, are you now sensitizing them? But and then I don't think testing can rule out confounding factors such as reaction to the surgical preparation, post-operative cleaning solutions, or components of the dressings themselves if you put dressings over top. This was a case study that showed that these similar compounds, the ethyl and butyl cyanoacrylate, which can be found in things like false eyelash glue, nail glue, and super glue, or this is Aran alpha glue, which is a similar compound. This was the first case study that shows you can sensitize with those other products and then have a reaction to Dermabond. So is there a role for trialing patients at home if they don't know if they've ever had a reaction, to see if any sort of patch testing erupts? This is another case. It's a 50-year-old female. She had painful tibial hardware removal. She denies any prior Dermabond use, and her initial surgery was done at outside hospital over 6 years ago. She reports she does have baseline sensitivities to adhesives. She was treated with topical steroids and then prednisone, which she found the most helpful, antibiotics for 7 days, and was healed at 1 month. These are some of her pictures, post-op day 7, 8, 9, 16, and then about a month later, she's doing well. So what are the treatment recommendations? I think you can work to prevent sensitization with proper techniques. Skin edges must be absolutely opposed to prevent inversion of the wound edges and sensitization if the Dermabond gets below the epithelial layer. It's important to rapidly distinguish between infection and contact dermatitis reaction, and then quickly remove the offending agent. Clean the area with soap and water and keep it dry. Steroids are the mainstay of treatment, as with any contact dermatitis. You can use a topical petroleum-based steroid to not only treat the symptoms, but dissolve the Dermabond. But be sure to avoid any steroids directly on the incision as much as possible. And then if it's severe or the patient is having a lot of symptoms, you can use oral steroids. Benadryl as helpful for pruritus, and then antibiotics if there's any signs of secondary infection. I think as this is rare and we've seen some pretty variable examples, the literature supports individualized plan based on the degree of reactivity. One more case, this is a 49-year-old female. She had a left proximal hamstring repair. She does report environmental allergies with prior Dermabond exposure without reaction. She underwent treatment with Bactrim as there was concern for some folliculitis, and she had a past medical history of MRSA. She continued with her home Zyrtec with even Pepcid and Benadryl at night. And although I have no other pictures, she is doing well, and this is reports it's healing. So in review, tissue adhesives are reported to improve wound strength, to provide an antibacterial barrier to skin flora, decrease operative time, negate the need for suture removal, and improve scar aesthetics. They reach the maximum bonding strength at about 2.5 minutes and are equivalent to healed tissue at post-op day 7. Diagnosis is made with a good clinical exam. You have geometric borders of erythema, may show blistering, absence of warmth, tenderness, fluctuance, and purulence, which would be consistent with infection. And then pruritus is typically more common. Again, these can mimic surgical site infections. They can compromise wound healing, result in wound dehiscence, and then initiation of steroids is helpful to mitigate the symptoms. There has been recent literature looking into simply asking the patient what they would like, especially if there's a risk they're going to have a bad reaction. Then you get shared decision-making with this. This was 163 total joints patients. They were given a handout with information, and then they got to choose. 12 chose staples, but there was no statistical significant difference in outcomes. So what would be my suggestions or takeaway after all the research I've looked into? I think there's great benefits using both the Dermabond Advance and Pereneo over a well-approximated closure with subcuticular suture. The proper patient selection and proper placement technique are pivotal. I think there's a role for some quick screening questionnaires, either preoperatively or in the clinic. Have you ever had surgery before, and did they use some form of glue? Did you have any reactions? If you don't know, maybe trial some eyelash glue at home. Are you overall a adhesive sensitive person? Because this could lead you to use Dermabond over Pereneo, and then you can ask the patient what they would prefer. If a reaction does occur, remove the agent, keep it dry, topical versus oral steroids depending on degree of reaction. Benadryl is needed, antibiotics if concerned for infection, then just have them follow up in a week. And usually patients, once they start treatment, tend to improve by that time. And then dermatology or allergist referral if extreme reaction, if you have any concerns or the patient requests it. Some studies that could be done in future directions. I think there still needs to be comprehensive studies to better define this incidence. There's small studies here and there, but I don't think they accurately reflect the occurrence of this. There's some suggestion that any postoperative occlusive dressing increases the rate of sensitization, but I haven't found specific studies to this. There could be a role for changing the formulation to make it more inert once on skin while still retaining the strength. And then easy and improved ways to test sensitization, aside from patch testing, which is pretty extensive. Oops. And then studying a protocol for asking patients what they would prefer. And then there is some role with pumpkin in decreasing an allergic response. They looked at, it was a rat study, but it was depression associated with chronic contact dermatitis, and both topical and oral pumpkin together actually decreases the signs and symptoms of contact dermatitis and the histopathological score. And then here's a small tidbit courtesy of Dr. Reese, but this is actually a pretty good study that shows covering the Dermabond, adding OR lights or a hot water bath can actually make it dry a little bit faster, up to 30 seconds. So if you're ever bored or waiting for the Dermabond to dry, you can bring the OR lights a little closer. Special thank you to Dr. Shu, Dr. Kwan, Dr. Weeks, Dr. Plosky, Dr. Jolasane for providing some patience, and then Dr. Hassan Seymour for reviewing this for me, as well as for my class, who is the best. Here are some of my references, and then I'll take any questions.
Ainsley, great topic. Thank you guys for kind of combining those two together. It's sort of interesting to think about all the factors that go into these things. So two questions I have, which I'm always, I'm still trying to figure out what to do with all these things. I use a little bit of everything. I pick different wounds, so I have no specific protocol. But the things that I have seen anecdotally, which bias my own thinking about it, and I wonder if that was described better in any of these studies, was a dressing placed over the Dermabond ultimately? Because some people put Dermabond or Printy on and then they still put something over it. So that's question one. And if I thought of it, especially because one of those wounds had sort of that, surrounding, very geographic pattern, which I've seen from Aquacell dressings, where it's that's the exact skin contact from that. So, the confounding factor of that element. The other one was, what type of skin prep was used during surgery, and was it appropriately cleaned off? I mean, we see people with skin reactions. I mean, peds can probably say it the most, who had ChloraPrep used and then put under a cast, and they have reactions. So is there any confounding, evidence in some of these prospective studies? Did they have like a protocol for cleaning the skin, or was the same skin prep used? I mean, there's a lot of, things that I always try and figure out which one's causing what.
Yeah, that's why I think with the patch testing, it's interesting, because I don't know of how you can truly define that that's what's causing the reaction, because there's so many other confounding factors on the skin. All the randomized control trials I looked at did have a set protocol for how they did skin prep, and they talked about that. So, but it is a good, does increase a good question. I think something that I thought was interesting too is how much humidity in the local environment influences the Dermabond reaction. And if you use alcohol and you dehydrate the skin, are you more likely to have a higher reaction? I didn't find any study that talks about it, but it could be a good basic science study, including skin prep. Olivia?
I was just saying, I do wonder though, with like the humidity aspect for the polymerization, some people will like add a drop of water or something while it's like trying to get it to try to dry faster.
Oh, I've never seen anyone do that.
I subjectively feel like that actually decreases the adhesion to the skin, like it polymerizes to itself, but it doesn't stick to the skin. So, because I don't know, I feel like people are always looking at ways to try to get it to dry faster.
Well, I gave them 3.
Yeah.
So. Dr. Marvin?
Ainsley, I'm sure that some of my colleagues have mash units in their home similar to mine. Our kitchen table has often been used for the suturing for friends and neighbors and whatnot. And, I know your topic was really the specific to wound closures. for surgical patients. But do you have a sense of what I don't ever remember seeing a kid react to Dermabond, or one of my friends that, what's the overall concern about reactivity to Dermabond in all comers?
So
Yeah.
that one study,
It's gotta be low,
the one study quoted it at 14%.
14?
Mm-hmm. And it was only 100 patients. The overall, all the studies I could find ranged from 0.5% to 14. There's no really good study that has a large patient population. I think there's still a realm for national or international studies on reports of this because it is rare, and I think it does differ based on the patient population you look at. But it does occur in kids. But it's a great question to better. I did talk to one of the Ethicon reps about this to know if they've been seeing higher numbers, because it makes sense if more people are using it, more people are getting sensitized, and so you're having more reactions. He said they're not getting report that the incidence is going up, but a lot of the literature, the primary literature hypothesizes that it is. And we're going to see it more and more.
Well, I have to say, I love the data that shows like decreased OR time, because I find it's more OR time because we're still doing a subcuticular closure and then waiting for that to dry as on top of that, as opposed to just putting a dressing on and being done. So I was kind of like personally kind of laughed at that data. Like that,
Yeah, I mean, the drying time at the end of a scoli to me is just my time to take a deep breath and kind of relax a little bit. This one safety piece I'll add with the current Dermabond is you want to be real cautious about squeezing too hard. So you break a glass, and I had not had a resident, but I know of some friends that have been trying to squeeze out the Dermabond, and the glass is punctured through it and caught their finger. So you're breaking kind of glass, and
Yeah.
I have seen it or heard of it cutting people, so just be cautious with that. You're trying to squeeze out that last little bit of Dermabond. So I'd rather use one extra one than have an injury there.
I did ask because I feel like in the past year, it's been like I've gotten less out of a Dermabond tube. So I asked if they changed the formula recently. They said no, but I've asked other people who feel the same, that you just get like more dries in the tip, and you end up needing an extra one depending on the length of the incision. I'll get back to you on that, but they've told me no, that they haven't changed it. So I don't know if it's user error or what, but.
Thanks, Ainsley.
It's been recalled like the 1,000 roots.